Hey, Chibis! I'm Aiwe, and today we are talking about how therapy separates emotional validation from diagnosing absent people. If you enjoy stories like this, hit the like button and subscribe if you haven't already. Let's go! Act 1. The question behind the accusation. What if the most useful question in therapy is not who is the villain, but what can we know, what are we guessing, and what could reduce harm? In the next 10 minutes, we will examine why a therapist may validate someone's pain without endorsing every conclusion, why diagnosis cannot be outsourced to gossip, and how responsibility can be discussed without blaming people for being abused. Imagine someone describing a relationship that seems impossible. Their parent is cruel. Their partner is manipulative. Their colleagues are hostile. Their friends keep abandoning them. The listener may feel an immediate pull to decide who is innocent and who is dangerous. But a therapist is usually not hearing from every person involved. The clinician has the client's account, the client's behavior in the room, relevant records, and sometimes information from other people when consent and clinical circumstances allow it. That is valuable evidence, but it is not a complete surveillance system. Two people can describe the same argument differently without either person deliberately lying. Memory is selective. Shame changes what people reveal. Fear changes what they notice. Anger makes some details vivid and others disappear. A therapist's job is generally treatment and assessment, not a legal verdict about an absent family member. That does not mean the client's story is dismissed. It means the story is held with care and curiosity. Something painful can have happened, and the client's interpretation of that event can still be incomplete. Those are not competing possibilities. Act 2. 3 layers of a story. A useful way to think about any relationship account is to separate 3 layers. First, what happened. Second, what the person believes it meant. Third, how they responded. Suppose a friend cancels dinner without explaining. The event is a cancellation. The interpretation might be, they are punishing me, or something came up. The response could be a calm question, a furious message, or a decision to withdraw. Each layer matters, but they are not interchangeable. Therapy can validate the emotional impact without certifying the theory. It makes sense that you felt rejected is different from your friend definitely wanted to humiliate you. Emotional validation says the reaction has a history and deserves attention. It does not declare every explanation accurate. This distinction becomes especially important when a person repeatedly describes conflict but cannot identify any contribution they make to it. Yet, even here, caution is essential. Repeated victimization does not prove that the person is causing the abuse. Trauma, coercion, poverty, discrimination, unsafe workplaces, grooming, and limited support can all trap someone in harmful situations. The careful question is not, why did you allow this? Abuse is not created by the victim's failure to escape. A better question is, given the constraints you face, what options might improve safety, support, or control? Responsibility should identify realistic choices, not rewrite the history of harm. Psychology sometimes uses the term locus of control to describe how people explain outcomes. Someone may see life as shaped mostly by their own actions, mostly by outside forces, or by an interaction between both. This is not a diagnosis, and an external explanation is not automatically irrational. Sometimes outside forces really do control the available choices. Act 3. Labels are not shortcuts. When a person says, my ex is a narcissist, the statement may be expressing pain, confusion, or a genuine concern about a pattern, but it is not by itself a clinical assessment. Narcissism can refer to ordinary self-focus, vulnerable self-esteem, recognizable traits, or narcissistic personality disorder. Those meanings are not identical. The same caution applies to terms such as borderline, sociopath, or bipolar. A few episodes of anger, jealousy, withdrawal, impulsivity, or emotional intensity cannot establish a diagnosis. Clinicians consider patterns across settings, how long they have lasted, how much impairment they cause. developmental history, and other explanations that might fit. Bipolar disorder and borderline personality disorder can share features such as impulsivity, irritability, and changes in mood, but they require different diagnostic questions. Bipolar disorder involves sustained episodes of mania, hypomania, or depression. Borderline personality disorder involves a broader, enduring pattern that may include unstable relationships, fear of abandonment, identity disturbance, impulsivity, self-harm, and strong emotional reactivity. Rapid mood changes after an argument should not automatically be assigned to either condition. Trauma, sleep loss, depression, anxiety, substance use, medical issues, and ordinary distress can produce overlapping signs. The conditions can also occur together. A diagnosis may change as a clinician gathers more history over time. This is why diagnosing a person who is not in the room is ethically and clinically risky. A therapist may discuss a client's experience of another person, help assess danger, and identify relationship patterns. But assigning a found disorder to an absent third party from secondhand stories turns a hypothesis into a verdict. Clinicians are not immune to error either. They can anchor on an early impression, overvalue a dramatic narrative, seek evidence that confirms a favorite theory, or react personally to a client's behavior. Supervision, consultation, structured assessment, records, and outcome monitoring can reduce these errors, but none makes a therapist infallible. Act 4. The work between feeling and action. One concept relevant to interpersonal life is mentalization, sometimes called reflective functioning. It means recognizing that people have minds, your own mind, another person's mind, and uncertainty about both. It is more than being nice or empathetic. It includes the ability to think, I feel certain, but my interpretation could still be incomplete. Under intense shame, anger, trauma activation, exhaustion, or sleep deprivation, this ability can narrow. Someone may experience hurt and immediately treat that hurt as proof of hostile intent. If a friend succeeds, the thought may become, they did this to make me look inferior. The feeling is real. The motive remains uncertain. A therapist might explore the moment with questions such as, what did the person actually say? What are you inferring? What else could explain it? And how did you respond after the feeling appeared? These questions are not designed to shame the client. They create space between emotion, interpretation, and action. That space can prevent a painful cycle. If every complaint is rejected as an attack, relationships may collapse. If every disagreement becomes proof of betrayal, the person may cut off one relationship after another and carry the same alarm into the next. The goal is not to force someone to accept unfair criticism. It is to examine feedback without assuming that disagreement is impossible. Agency is found in that separation. A person may not control another individual's cruelty, a manager's decision, or a partner's coercion. They may still have some choices about seeking help, setting boundaries, documenting events, leaving when feasible, or changing their own response. The size of that choice depends on safety and circumstances. Act 5. Why therapy can look quiet from the outside. Therapy is not one method with one purpose. Supportive therapy may help someone survive grief, illness, isolation, disability, acute stress, or a period when daily life is barely manageable. Other approaches focus more directly on behavior, thoughts, trauma, emotional regulation, relationships, or long-standing personality patterns. A therapist may also build trust before offering challenging feedback. If a person is at risk of self-harm, violence, substance-related harm, homelessness, or treatment dropout, keeping them engaged can be an immediate clinical priority. A calm response is not automatically agreement. Sometimes it is a condition that makes later honesty possible. From the outside, years of therapy can look like proof that nothing is changing, but observers may not see fewer crises, better safety planning, improved emotional regulation, medication adherence, or a growing ability to notice patterns. On the other hand, therapy takes time, should not become an excuse to avoid review. Treatment goals can be measured, revised, or replaced, A second opinion or a different approach may be appropriate. The strongest therapy is not necessarily the most confrontational. Direct feedback helps some clients. Others first need stabilization and enough trust to tolerate shame without becoming overwhelmed. Effectiveness depends on the person, the goals, the risks, the treatment stage, and the fit between clinician and client. So what should a responsible therapeutic conversation sound like? It might ask, what is directly known? What is inferred? What pattern keeps repeating? What part is within your control? What safety steps are realistic? And what evidence would support a different explanation? The synthesis is simple but demanding. Good therapy does not require choosing between compassion and accountability. It can say, you are harmed, and also ask, how can we protect you now? It can say, your feelings make sense, while adding, your conclusion may need testing. It can recognize another person's wrongdoing without pretending the client has no agency at all. The next time you hear a dramatic diagnosis attached to an absent person, slow down. Ask what is known, what is being inferred, what risks are present, and what action could reduce harm without requiring a perfect label. The most useful therapy does not hand us a villain. It helps us see the whole system clearly enough to choose a safer next step. If this framework helped you think more carefully about therapy and relationships, consider subscribing for more evidence-focused psychology. And if a situation feels unsafe, seek support from a qualified professional or an appropriate local service rather than trying to diagnose anyone from a distance.